Yeah, we'll go to the next.
Dr. Radhika, please come on the second podium because we are
Running late, yeah. Please come. So Radhika will be speaking on site Imperilled, addressing mumps associated uveitis. And Dr. Girish is there.
Please be ready so that as she finishes.
Dr. Girish Gadre. Yeah. Yeah, I think so. Yes,
Ma'am, they are selecting.
ये लोग गाली
Start the
देंगे.
presentation.
Yes.
Start. बेटा.
2395.
अच्छा ये है क्या? Oh, shit. गाली देंगे.
Okay. Good morning, everyone. Today, via this case series, I'll be addressing mumps associated uveitis. The first patient of ours was an 8-year-old male residing in the southern state of Karnataka, presented to us with sudden painless diminution of vision in both the eyes for the past 3 days. He had a history of systemic fever with swelling near the neck 2 weeks prior to the development of his ocular symptoms. He was vaccinated up to age according to the Indian National Immunization Schedule. On further inquiry, the patient's sister also had a history of mumps-associated parotitis. On ocular examination, his best-corrected visual acuity was hand movements in both the eyes. Intraocular pressures were normal. Anterior segment showed presence of pigments on the corneal endothelium. Sluggish pupillary reaction. AC was quiet. On fundus examination, he had mild temporal dyspallor in both the eyes, and what we noticed was the presence of this multifocal cerebriform pattern of retinitis along the vessels with perivascular clearing present in all the quadrants in both the eyes. OCT showed the presence of posterior vitreous phase cells, distortion of the retinal architecture, and hyperreflectivity of the inner and outer retinal layers in both the eyes, along with loss of foveal contour. Considering the clinical history and ophthalmic examination, a provisional diagnosis of bilateral outer retinitis secondary to mumps virus was made. An empirical dose of oral acyclovir 400 milligrams was started and was referred to the pediatric neurologist to rule out any CNS involvement. His CNS examination was within normal limits. However, his MRI-weighted T1 axial scan showed hyperintense bilateral parotid gland. CSF analysis was normal. Ancillary blood investigation showed a positive serum mumps, IgM and IgG levels. So, considering his systemic history with findings of multifocal retinitis, OCT showing distortion of the outer retinal layers, supported radiologically and serologically, a diagnosis of bilateral outer retinitis secondary to mumps virus was made. The patient was then started on intravenous methylprednisolone 500 milligrams per day for 3 days, followed by a course of tapering dose of oral steroids 1 milligram per body weight. 1 week post his IVMP treatment, the vision did not improve. It was still hand motions in both the eyes. However, the fundus examination showed resolution of the retinitis lesions, but the OCT still showed presence of posterior vitreous phase cells and distortion of the outer retinal layers. Considering that there was no improvement in vision and OCT still showing presence of distortion of the outer retinal layers, a trial of hyperbaric oxygen therapy as a rescue therapy was considered in this patient with continuation of oral steroids. What hyperbaric oxygen does is it increases the partial pressure of oxygen from 21 to 23%, increasing the nitric oxide synthesis, thereby increasing the transfer of oxygen to the tissues. After ruling out any ear, nose, throat or respiratory infection, a 2.5 atmosphere absolute oxygen was administered to the patient for 1 hour by direct respiration per day. This was one session, and 40 such sessions was given to the patient. Post the hyperbaric oxygen treatment, his best corrected visual acuity in the right eye was hand motions, whereas in the left eye it improved to 6/9. His intraocular pressures were normal, anterior segment was quiet. Fundus examination still showed mild temporal dyspallors, but the patient developed these nummular lesions all over the retina. IR autofluorescence showed hyperautofluorescence. OCT post-treatment, in the lower panel we can see that the posterior vitreous cells had resolved, the foveal contour was normal, restoration of the inner retinal layer, but there was still mild distortion of the outer retinal layers. Full field ERG showed undetectable scotopic and photopic response in both the eyes, whereas multifocal ERG showed light response only in the central area. A tear cytokine profile was done using a biopath M finder, which showed pre-treatment there was raised cytokine levels, most of it which reduced post IVMP and hyperbaric oxygen therapy. We saw 2 more patients with similar in the similar age group. With a systemic history of fever with bilateral neck, having counting fingers close to face in one eye, in one patient, and hand motions in the other. with a similar presentation in the fundus. In addition, these patients also had a bilateral optic nerve involvement, and one of the patient also had encephalitis. They underwent similar treatment, but unfortunately, they had poor visual outcome. So, if a patient presents to you with a systemic history of fever, with bilateral neck swelling, and you see a cerebriform pattern of retinitis, most likely it is secondary to mumps virus. And since there is no specific treatment antiviral available for mumps, the patient can be started on intravenous started on anti-inflammatory therapy, which might reduce the inflammatory load and probably patient might have a good visual outcome. As we say, prevention is better than cure. Inclusion of mumps vaccine in the national immunization schedule, along with measles and rubella, may protect the child from developing this visually debilitating condition. These are my acknowledgements. Thank you.
A very fantastic presentation. Very good. Thank you.
Thank you.